Welcome to the MRCPology channel for a quick review, understanding, and revision of the topic. Imagine a patient arrives with an explosive retro-orbital headache, vomiting, double vision, and suddenly becomes hypotensive and drowsy. The first thought may be subarachnoid hemorrhage or meningitis, but in MRCP, this pattern should also make you think of pituitary apoplexy. Pituitary apoplexy means acute hemorrhage or infarction within a pituitary adenoma. In simple terms, a pituitary tumor suddenly bleeds or loses its blood supply. This causes rapid expansion inside the sella, which is the small bony cavity where the pituitary gland sits. Because the space is tight, even a small sudden increase in volume can compress nearby structures and destroy pituitary function. To understand pituitary apoplexy, think in 4 boxes: sudden sellar expansion, optic chiasm compression, cavernous sinus compression, and acute pituitary hormone failure. First, sudden sellar expansion. Pituitary apoplexy usually occurs in a pre-existing pituitary macroadenoma. A macroadenoma means a pituitary adenoma larger than 1 centimeter. The tumor may outgrow its blood supply, or it may bleed into itself. Tumor bleeding or infarction leads to rapid expansion inside the sella. This stretches the diaphragma sella, which is the dural roof over the pituitary fossa. That stretch explains the classic sudden, severe headache, often felt behind the eyes. Second, upward expansion compresses the optic chiasm. The optic chiasm is where the optic nerve fibers cross above the pituitary. Compression here classically causes bitemporal hemianopia, meaning loss of the outer half of vision in both eyes. Patients may also have reduced visual acuity if the compression is severe. The key clue is headache plus visual field loss in a patient who may have an undiagnosed pituitary adenoma. Third, lateral expansion can enter the cavernous sinus. The cavernous sinus is a venous space beside the pituitary that contains cranial nerves controlling eye movement, especially cranial nerves 3, 4, and 6. Compression of these nerves causes ophthalmoplegia, which means weakness or paralysis of eye movements. Clinically, this gives diplopia, ptosis, and painful eye movement disturbance. Cranial nerve 3 palsy is particularly common, so a patient may have ptosis, a dilated pupil, or the eye sitting down and out. Fourth, and most importantly, pituitary destruction and stalk compression can cause acute ACTH deficiency. ACTH is the pituitary hormone that stimulates the adrenal glands to produce cortisol. If ACTH suddenly falls, cortisol falls. Low cortisol means poor vascular tone, poor catecholamine responsiveness, hypoglycemia, hyponatremia, hypotension, shock, and reduced consciousness. This is the life-threatening part of pituitary apoplexy. MRCP trap: do not focus only on the eyes and forget the adrenal crisis. The posterior pituitary is less commonly affected, so diabetes insipidus is less common than in some other sellar emergencies. Diabetes insipidus means passing large volumes of dilute urine due to lack of antidiuretic hormone effect. Its absence does not exclude pituitary apoplexy. Clinically, the classical picture is sudden severe headache, often retro-orbital, with nausea, vomiting, and sometimes meningism. Meningism means neck stiffness and photophobia due to irritation of the meninges, which can make the presentation look like subarachnoid hemorrhage or meningitis. Visual field loss, reduced visual acuity, diplopia, ophthalmoplegia, altered consciousness, hypotension, hypoglycemia, and hyponatremia all strengthen the diagnosis. Do not confuse this with subarachnoid hemorrhage, meningitis, cavernous sinus thrombosis, or migraine. Subarachnoid hemorrhage gives thunderclap headache and may cause reduced consciousness, but it does not typically cause acute pituitary hormone failure. Meningitis gives fever, neck stiffness, and confusion, but the combination of ophthalmoplegia and visual field loss should push you towards a sellar or cavernous sinus process. Cavernous sinus thrombosis can cause painful ophthalmoplegia, but the adrenal crisis picture and sellar mass point towards pituitary apoplexy. Migraine should be a diagnosis of caution when there are objective cranial nerve signs or visual field defects. Now, diagnosis. The best imaging test is MRI of the pituitary. MRI can show a hemorrhagic or infarcted sellar mass. Hemorrhagic means there is bleeding. Infarcted means the tissue has lost its blood supply and undergone ischemic injury. On the MRI image, what you are looking for is an abnormal mass in the sellar region, where the pituitary should be. It may look enlarged and irregular, and if there is bleeding or infarction, the signal can look mixed rather than uniform. The key teaching point is not just that there is a pituitary mass, but that it is an acutely damaged pituitary adenoma causing expansion and compression. If the mass extends upward, it can approach or compress the optic chiasm, explaining bitemporal visual field loss. If it extends sideways, it can involve the cavernous sinus, explaining diplopia, ptosis, and ophthalmoplegia. So when you show this MRI, link the image directly to the symptoms. Sellar mass expansion gives headache, upward compression gives visual field loss, lateral compression gives cranial nerve palsies, and pituitary destruction gives adrenal crisis. CT head may be done first because the presentation can mimic subarachnoid hemorrhage. CT may show sellar hemorrhage, but it can miss pituitary apoplexy, so a normal CT does not safely exclude the diagnosis if the clinical picture fits. Blood tests are important, but they must not delay emergency treatment. If it is safe and does not delay steroids, send cortisol, ACTH, thyroid function with TSH and free T4, prolactin, LH and FSH, testosterone or estradiol, IGF-1, UNS, glucose, full blood count, and clotting. UNES means urea and electrolytes, especially sodium, because hyponatremia is common in cortisol deficiency. Formal visual fields and visual acuity should be assessed once the patient is stable because they guide the need for surgery. Treatment is urgent because pituitary apoplexy is both an endocrine and neurosurgical emergency. The first management step not to miss is hydrocortisone. Give hydrocortisone immediately if there is hemodynamic instability, reduced consciousness, visual compromise, or significant suspicion of adrenal insufficiency. A typical emergency regimen is 100 to 200 milligrams intravenously as a bolus, followed by an infusion or repeated high-dose dosing. The reason hydrocortisone matters is physiological. Acute ACTH deficiency leads to low cortisol. Low cortisol leads to loss of vascular tone and poor response to catecholamines. Hydrocortisone replaces the missing cortisol, restores vascular responsiveness, treats or prevents adrenal crisis, and can be life-saving. Supportive care is also essential. Give fluids, correct hypoglycemia, correct electrolyte disturbance carefully, treat nausea and vomiting, and provide analgesia. The patient needs urgent endocrine and neurosurgical review. Transsphenoidal decompression is considered when there is severe or worsening visual acuity loss, worsening visual field loss, deteriorating consciousness, or major neuroophthalmic compromise. Transsphenoidal means the surgeon approaches the pituitary through the sphenoid sinus, usually via the nose, to decompress the sellar contents. Conservative management may be appropriate if the visual deficits are mild and stable, and the patient improves with steroids and supportive treatment. Long-term, pituitary function must be reassessed because permanent hypopituitarism is common. Hypopituitarism means reduced pituitary hormone production. Patients may need glucocorticoid replacement, levothyroxine, sex steroid replacement, and sometimes growth hormone replacement. MRCP trap. Never start levothyroxine before treating cortisol deficiency because increasing metabolism in an untreated cortisol-deficient patient can precipitate adrenal crisis. If you remember one thing, remember this. Pituitary apoplexy is sudden headache plus visual or cranial nerve signs plus acute pituitary failure, and the emergency treatment you must not miss is hydrocortisone. Quick recall. A patient presents with sudden retro-orbital headache, vomiting, ptosis, diplopia, hyponatremia, and hypotension. CT head is not diagnostic. What is the immediate treatment priority and why? The answer is immediate intravenous hydrocortisone because pituitary apoplexy can cause acute ACTH deficiency leading to cortisol deficiency, shock, hyponatremia, hypoglycemia, and reduced consciousness. A patient with suspected pituitary apoplexy has bitemporal hemianopia and a third nerve palsy. Which anatomical structures explain these findings, and what imaging test best confirms the diagnosis? The answer is optic chiasm compression, causing bitemporal hemianopia and cavernous sinus involvement, causing third nerve palsy. MRI pituitary is the best test to show the hemorrhagic or infarcted sellar mass. Do subscribe to the channel for further videos.